Good afternoon. My name is Anett Rancz and my thesis is the invisible presence microscopic colitis. I'm a first-year PhD student in the gastroenterology and endocrinology group of the CTM, and I am also part of a 12-month fellowship program provided by the Moll Foundation for the Community. In my vision, there are vigilant physicians who educate patients in order to prevent the development of the disease microscopic colitis. For that, my mission is to provide professional knowledge to the physicians about the clinically relevant risk factors of microscopic colitis. For that to achieve, I have two ongoing projects. My first topic is microscopic colitis is a risk factor for low bone density. In Europe, the prevalence of microscopic colitis is around 119 cases per 100,000 persons. There are many confounding factors regarding the relationship of microscopic colitis with low bone density. First of all, both diseases are more frequent in elderly women. Moreover, postmenopausal women can get hormonal substitution treatment, which in turn can cause microscopic colitis. Furthermore, budesonide, which is the gold standard therapy for microscopic colitis, it is a corticosteroid with a low systemic bioavailability due to its high first-pass effect in the liver, but still, it is considered to be associated in a long-term therapy with the development of low bone density. So our aim is to scrutinize if microscopic colitis is a risk factor in the development of LBD. Our clinical question, is microscopic colitis a risk factor for developing bone mineral changes? We have the two frameworks, the PECO and the COCOPOP. We made our search on the 16th of October 2021. Our search key was constructed from two main parts. The first one contained microscopic colitis and the three subtypes of it, while the second part referred to osteoporosis and the synonyms of it. As you can see on the Prisma flowchart, we made our search in 5 different databases, and we got around 3,000 hits. And after all, we got 4 studies included in this analysis and review. My first outcome is if microscopic colitis is a risk factor in the development of LBD. Low bone density has 2 forms. The mild is osteopenia and the severe is osteoporosis. Its clinical relevance is that osteoporosis is a risk factor, is a risk for developing osteoporotic fractures. So we investigated microscopic colitis patients with low bone density in comparison to age and sex-matched controls. The I-square is 48%, which may suggest that there is a moderate heterogeneity. It could be because of the Rancz study paper, because it has a cross-sectional study design, it has the youngest and the smallest number of population, and in which not just microscopic colitis, but Crohn's disease patients are compared to healthy controls. So our overall measurement, the odds ratio is 2.96, which means that the odds for developing low bone density is around 3 times higher in the presence of microscopic colitis. Our next outcome is the proportion of LBD in MC patients. We investigated the microscopic colitis patients with low bone density. The I-square is 75%, suggests a considerable heterogeneity, which could be accounted to the Greenberg study, which is a conference abstract with the most aged population and the female predominance. Our overall measurement, the proportion is 0.68, which means that more than 2/3 of microscopic colitis patients has low bone density. Our next outcome is the proportion of osteopenia. We investigated MC patients with osteopenia. The I-square is 0%, might not be important, and the proportion is 0.51, which means that half of the MC patients has osteopenia. Our last outcome is the proportion of osteoporosis, and we investigated MC patients with osteoporosis. The I-square is also 0%, might not be important, and the overall measurement is 0.11, which means that the proportion of osteoporosis is 11% in microscopic colitis patients. All of our outcomes are at very low level on the certainty of evidence scale after the Great Pro Quality tool, because all of the included studies used a surrogate outcome measuring the bone mineral density all of the studies contained a low number of study participants, and there is a wide variance between the overall measurements confidence intervals across the studies. The strength of our study is that this is the first strong association of LBD and microscopic colitis, but we have several limitations. We have a small number of studies with different study designs, a low number of study participants, and a female predominance. Our conclusion is that the odds for developing low bone density is around 3 times higher in the presence of microscopic colitis. And the proportion of low bone density is 68, of osteopenia is 51, and of osteoporosis is 11% in the microscopic colitis population. The implications for research are that it's important to elucidate the fracture risk, and besides that, further prospective studies are needed to assess the prevalence of low bone density in microscopic colitis patients, and incidence studies shall be accomplished as well to gather more information through the follow-up times. The implications for practice are that microscopic colitis patients should be screened for bone mineral density in the moment of diagnosis and may be advised for lifestyle changes in order to prevent the development of LBD. This is a summary of my manuscript. I am ready with the methods and results part, and right now I am working on the discussion and introduction parts. My second topic, the risk factors for microscopic colitis. In Europe, the incidence of microscopic colitis is around 11.4 cases per 100,000 person-years. Medication use has been implicated in the development of microscopic colitis, while BMI, body mass index, is inversely associated with the development of microscopic colitis. So our aim is to assess the risk factors of MC in adult patients. Our clinical question is, what are the risk factors of microscopic colitis in adult patients? We are investigating unchangeable factors like age and gender, lifestyle, for example, smoking and BMI, and medications like SSRIs, PPIs, and NSAIDs. Our hypothesis is that with the presence of the risk factor, there is a higher chance to develop microscopic colitis. The clinical implication is screening and prevention. We made our systematic search on the 18th of December 2021 in 3 medical databases, and we got around 7,000 hits. Our search key contained only the microscopic colitis and the 3 subtypes of it, and we have already registered protocol at Prospero. Regarding the selection, the number of included full text for data extraction will be ready in 2 weeks. My goal is to submit the study papers during springtime of 2022. And I would like to close my presentation with the words of Beverly Hills, but not from Beverly Hills. There are no shortcuts to any place worth going. If anyone has questions, I'm glad to respond. Thank you.
Thank you, Anett, for your presentation. My question is, in your clinical implications, you've mentioned lifestyle changes to prevent low bone density. What do you recommend? What do you mean by lifestyle changes?
Thank you for your question. I would recommend, for example, vitamin D and calcium supplementation, more dairy products, lactate dairy products.
Okay, thank you.
My question is, what is the pathomechanism of osteoporosis in microscopic colitis?
It is still under debate, but they wrote down like the involvement of luminal factors, the dysregulation of the autoimmune response, and also a genetical background as well. But there is a debate about that.
Mm-hmm. There is no calcium loss, for example, through the watery diarrhea, which could be one explanation. What did you read in the literature?
So microscopic colitis, its main symptom is the chronic watery diarrhea. Yes, and through that, there is a big elimination of the calcium, yes, and so it could be accounted for that.
Thank you for the presentation. I would like to ask, how did you perform the grade assessment? Because based on the Coherent Handbook, that is for the intervention questions, not for prevalence.
There is a part for the prognostic meta-analysis, and I performed for my first outcome that, and there is also for prevalence, like for proportional meta-analysis, there is a tool which I could use.
So not with the Grade Pro tool, but with a different
Oh, one. Yeah, it's with the Grade Pro tool, but not the intervention part, but another part.
Okay, thank you.
May I go a bit deeper in this vitamin D question? What would you advise as a dose for vitamin D?
Like 2,000 milligrams per day. It is per day.
Okay, thank you. That's just because, you know, nowadays it's a challenging question because there were lower kind of advised dose and higher kind. So this is your opinion. Thank you.
Do you have any comparative data whether those patients who are treated with budesonide and those patients who are not treated, not getting any treatment for their microscopic colitis, is there any difference in the rate of bone mineral loss? Whether it is a side effect of the budesonide or whether it is the consequence of the disease, so that might give some explanation of the reason why the patient do develop.
We tried to find an answer for that, but there were like different types of steroids used, like for example inhalative steroid. They wrote down inhalative steroids use as well, and the treatment of the microscopic colitis, the budesonide as well, in these study papers. So we still don't know the real answer for that.